Armour Hansen had remarked in 1873, "There is no disease that so frequently gives rise to disorders of the eyes as does leprosy." Leprosy or Hansen's disease is a chronic granulomatous infectious disease caused by Mycobacterium leprae that primarily affects the peripheral nerves and skin. Leprosy can also affect eyes, mainly the anterior segment. Ridley and Joplin have classified Hansen's disease into 5 categories in decreasing order of immunologic resistance to Mycobacterium leprae. These categories are tuberculoid, borderline tuberculoid, borderline lepromatous, and lepromatous leprosy. It has been regrouped for therapeutic purposes into multibacillary or paucibacillary disease. Ocular involvement in Hansen's disease is greater in the multibacillary type. Scleritis is an uncommon complication seen in ocular leprosy. Incidence of scleritis in various reports varies from 0.3% to 1.6%. It can be caused by presence of Mycobacterium leprae in the sclera or could be autoimmune in nature. In the present case, a 32-year-old male presented with complaints of blurring of vision in the left eye, along with redness and photophobia for 15 days. There was no history of ocular trauma preceding this event. He was asymptomatic in his right eye. The patient had no previous medical or surgical intervention. The patient denied history of any systemic illness. In the left eye, the visual acuity was 20/40 and intraocular pressure was 4 mm of mercury. An oval-shaped mass was located temporarily in the left eye, mainly situated over the sclera but encroaching over the limbus and adjacent cornea at 3 o'clock position. This mass measured approximately 4 mm horizontally and 6 mm vertically. It was firm in consistency and the overlying conjunctiva was freely mobile, but the mass was firmly adhered to the underlying structures. The anterior chamber was irregular and contained cells and exudates inferiorly. The pupil was peaked at the 3 o'clock position, corresponding to which there appeared to be a full thickness scleral melt with uveal prolapse below the conjunctiva. A subconjunctival bleb was noted at the limbus. The rest of the examination, including the fundus, was normal. On general examination, the patient showed the following features. General build was poor, leonine facies with the skin thickening on the forehead, coarse thickened skin on hands and feet, thickened ear lobules, thickened ulnar nerves, and discolored patchy skin changes below the neck. Our clinical diagnosis was nodular scleritis of the left eye, suspected Hansen's disease. Laboratory workup was advised, which included Mantoux tests, dermatological consultation, and possible split skin smear of the ear lobule. However, the patient could not afford these tests. For tissue diagnosis of the disease and also for tectonic support, a scleral patch graft with excision biopsy of scleral nodule was planned for the patient. Scleral patch graft is a well-known modality in the surgical management of cases with severe scleral melt encountered in immune-mediated scleritis. Scleral patch grafts have been used for a variety of indications, the most common being to cover the exposed part of the tubes in glaucoma drainage device. Infectious scleritis is a rare indication for this procedure. In this case, we resorted to this technique as there was scleral melt leading to hypotony. The patient was scheduled for surgery under local anesthesia. The area of the nodule was demarcated and the surrounding conjunctiva was dissected. Bleeding was expected and hemostasis was achieved by gentle cautery. The nodule was gently freed off the adjoining conjunctiva, taking care to preserve the nodule in toto. However, there was no clear cleavage plane between the posterior extent and underlying healthy sclera. Therefore, the nodule was excised flush with the base. The dimensions of the required graft were measured with the help of a calipers, and a partial thickness scleral patch was hand-fashioned using donor sclera. This was sutured using tenno nylon and fibrin glue. On the first post-operative day, his visual acuity was 20/40. The intraocular pressure in the left eye was 6 mm of mercury. He was started on topical steroids and antibiotics. On post-operative follow-up 1 week later, the patient was doing well. The graft was in place. Histopathology of the scleral nodule showed the presence of colonies of Mycobacterium leprae bacilli, both in hematoxylin and eosin stain and 1% acid-fast stain. This helped provide a tissue diagnosis for his ocular condition, and the morphology and numbers of bacilli suggested live bacilli. The patient was also reviewed by our in-house internist and started on systemic multi-drug therapy for leprosy. The patient is on regular follow-up, and 3 months later, his visual acuity is 20/50 and intraocular pressure is now 16 mm of mercury. The graft is doing well with no recurrence so far. The topical steroids have been tapered and discontinued, while systemic treatment for leprosy will be continued for 1 year. The patient has since then been successfully initiated on therapy and has been brought into the district leprosy control program. This was a rare case of a patient with scleral nodule due to Hansen's disease. Definite tissue diagnosis was made after excision biopsy of the infected nodule, and a scleral patch graft was used to successfully establish the tectonicity of the globe.